Right now, I think at the very end, before we break the lunch. No, I think it'll take 2 hours. Yeah, let's do it. Let's do it. Okay, I can start. Still morning now? I can start now. Okay. Is it still morning? Are we in the morning? Still in the morning?
Good morning.
Oh. Good morning, all. I was just checking my time, but we are morning now in PM. But welcome you all this morning to this special meeting. I call it a special meeting because special people, special training that we have been doing for since 2013. I'll just make an introduction to the purpose of this meeting this morning. And first of all,
Before I go on, I want to introduce and thank you for our team down in Australia, led by Professor David Duran from the New England and University of Newcastle, and the team down there. I think they're on Zoom now. If they are listening, maybe we cannot hear from them, but they are listening in. So thank you for joining us this morning, David. I think we have crossed the line some time ago on a virtual meeting. So thank you for joining this morning again. And also I want to thank Dr. Nick Harris from DFET Commonwealth for joining us this morning as well on virtual. And here in the room we have a team from DFET, Selena Smith and Laura Andrews. Laura's I've met her before in the cholera outbreak. So thank you for joining us again this morning, and I hope we will give you some information, insight on how far we have come from the last time that we have done cholera outbreak to now COVID outbreak with COVID with the FETPNG training program. Also here we have our team, our usual team from the New England and University of Newcastle, who've come all the way here to help us run the FET training program. That's Joanne, Celeste, Laura, and James. James has been with us since 2014 with the second cohort, and he's still with us, and I regard him as my senior advisor to FET program in Papua New Guinea. And so he's, I don't know when we're going to disconnect, but I think he's still very young, and I'm still also very young, so we'll probably keep on going. So long as we have that demand and need for field epidemic training in Papua New Guinea. And also I'd like to thank the local faculty members who has been with us, Dr. Matis Barry from Western Provincial PHA. He's also a FET faculty member. He's also had we went together for the FET training in India. But through FETPNG, I guess we have also developed him. It's one of the good clinicians turned into public health, I believe. And he's the director for public health down in Western Province. So he's a faculty member. We also have Betsiba from West New Britain, who's also a local faculty member. She's the surveillance officer in West New Britain Province. We have Harris here from Autonomous Region of Bougainville. He's the Deputy Secretary for Health in Autonomous Region of Bougainville. He's also the faculty member. These are senior faculty members of our own product in Papua New Guinea. And thank you again. Most importantly, thank you for the students. These students here, I don't call them students, my colleagues from the provinces. They've done the intermediate, which is a 9-month program, and now they're doing the advanced program. We started in 2019, but it was interrupted. But we continue to maintain the dialogue and support to them to do the work and training while they're on the field and virtual. So we'll give you some of those insights and updates as we go through. So I'll go to my slides. Come on. Arrow. That's it. Okay, the program of today's program is, as I've done some pre-introduction or introduction, it's overview from the past 2 weeks of advanced FET training by Bernnie, who's also a student, but also our FETPNG program convener. We just recruited here. And then there will be 5 minutes of presentation by fellows, by 4 fellows, to give their product and the work that they have been doing. And presented again by me to give an overview of what we have been doing on the FET training program and what we intend to do and continue to do for FET training program. And right after that, I hope we can meet and have a lunch together, and we can chat and talk about more about FET training program, but also other things that we can talk about. Okay, as I said earlier, we started our FET training program in it's a 9-month program. We started in 2013. Before that, we had 5 graduates from India FETP program. That's the 3 months compressed, sort of that's national NID in India, supported by World Health Organization. And we also have the 18-month advanced program, which this group is coming from. We initially recruited 30 from the 7 cohorts that we had from 2013 to 2018. And from there, we come down to 17 remaining from the 30 recruits, and they've continued their work and and now we have a plan to do the 3-month frontline training. This is basically for rural health centers and districts. Again, this is more like to be inclusive in the training program and basic stuff. We also, the PNC FET training program also added another program activity under the FET program, the development of rapid response team training. We've also done some trainings already during this COVID. I think total of 7 now, 5 last year, and then 2 just quite recently, a couple of weeks ago. We also have included in the FET training program a leadership development program. And also we do the faculty development program to upskill them and to teach them the skills of delivering lessons and those kind of thing. In the FET training program, we also do operation research. And probably here, it may be not clear for those who are sitting right at the back, but it just outlines some of the things that we do under the FETP umbrella. So I think from the outset, maybe in the province or even at the national level, even our partners do not see, maybe they don't see this, that we have grown from just doing FET training, doing the 9-month training program, and then we've done more things than just we've done the frontline, we've done the advance, and as I said already, we also do leadership development and the alumni development, faculty development, and so I think there's a lot in there. At the moment, we're trying to see how we can be able to develop our capacity at the national department, so we can take on board some of these, things that we've started to continue. So that's our group photo here. We started the training at the Dixie's Hotel up at 17 miles. So I'll now hand over to Benny to continue from there.
Thank you, Mr. Ropan. Hi, everyone. Okay, I'll just give a brief update for the last 2 weeks. I mean, today we'll end our training, what have been happening at Dixie. Okay, we have the 2 weeks was very intensive and hectic for us, what Mr. Ropa mentioned, because we didn't have continuation of the training. So we had a very intensive, we're trying to catch up on things, refresh again. And it was very intensive, but very interactive as well. We learned a lot from each other and the fellows and faculty as well. So just a brief overview. On the first day, we had COVID-19 interaction review. Our fellows coming from almost 14 different provinces, sharing their experiences, lessons learned, what good practices they've exposed or they've been practicing during that pandemic response. So during the discussion, fellows were sharing their experiences, what went well during the response, what didn't go well, they also share, and those challenges that they faced, what were the root causes. So we had identified the causes, and we also come up with what we think are recommendations that we can implement to help address some of those causes. And also during that week, we also, on Monday last week, fellows also share what the training program has taught us, upskill us, and how we have used what we have learned through the training program especially during that pandemic response. And what gaps we identified. If only we were taught these things, we could have done that. And we hope that based on what we lacked additional training or upskilling can be done, and we can maybe better improve in the next response. So in the last week training, these were the training sessions that we underwent. Outbreak investigation, more advanced to what we initially taught in the initial training. Some Excel refresher to help analyze data, and field epidemiology methods we learned, descriptive data analysis, analytical data analysis, and the major project we were working on is to develop our intervention proposal, which will go back to implement, and the monitoring and evaluation of the project that we will be doing. For the second week, this week, we learned on project management, the overall concept of project management, how we can use that to do our project, our intervention project. And communication, we also learned on that, how we can communicate with communities, with our fellows or colleagues, different audiences, strategies to use. Leadership, we had session on that, how to be, as field epidemiologists, how to be good leaders in our field of work. Additional refresher on Excel. Then this afternoon, we will have just introduction to Power BI for those of us to help us to go back to, we can display our dashboard back in the province on the data that we collect. And we also had sessions on a powerful presentation, how we can construct and develop powerful slides to disseminate, doing our presentation to share with whatever audience there with us, so that the message is clear to all. And we had sessions on data analysis, and we were working on our intervention project. And yesterday we had the fellows at all 10s to do their presentation on the intervention project. And today, 4 of our fellow colleagues will also showcase or present to our partners and stakeholders the intervention project. That's all.
Hi, everyone. Those of you are in this room, and everyone who's joined us virtually as well. It's good to have everyone to show what we want to present to you all today. So I'm Israel. I work for NCD PHA and being part of this advanced field epidemiology training. And my intervention project, the major project that was looking into addressing the barriers affecting triage and reporting of COVID-19 suspected cases in NCD health facilities, April to June 2022. So you know that during the COVID pandemic, especially during the surge, the impact of the surge affected everyone throughout the country and across the globe. And particularly in NCD, we recorded some highest number of COVID cases, around 5,000 plus cases, to as high as 75 deaths in NCD. Yet these numbers are significantly low. And transmission, in NCD, we're vulnerable to high transmission due to the population density of the city. And as a new norm to that pandemic, triage became one important area in health facilities. So every patient going to a facility must present to a triage booth or table or site before he or she enters into the facility. So triage became one of the first points in any facility. And the importance of triage is to reduce the risk of transmission. If any suspected cases who went in without being triaged would spread not only to just patients, but staff. And of course, you are aware that staff were infected during this pandemic. And so triage plays that important role of trying to ensure that transmission doesn't happen within the facility and also identify case to detect for testing and so forth. Triage became an ideal opportunity for suspected cases to be reported as well. In my cross-sectional study that was conducted among 10 workers across 6 health facilities in NCD, it was noted that 60% of the healthcare workers who made the triage were nurses. So throughout the response, nurses mostly took part, along with community health workers. So those were the people who were actually standing in front to do the task. And one of the key things I want to highlight from these key findings is that times of conducting triage varied. People started at different times and didn't know when they would stop. If they decided to stop at any point, they would stop because they didn't know when they would stop. So let's say, so in the morning, if a large number of people came, they would triage this group of people. And once they got rid of the number, and anyone who came late, they would not see them. Because there was no consistency that was seen. And also those who were suspected at triage were referred for testing, but we didn't know how many actually that we suspected at triage actually ended up there. So there was this gap being created. And so this intervention, the goal of this intervention of addressing barriers at triage is to implement daily triaging and reporting of what's happening at triage so that we can know what's really happening and how triage is being performed. And so there are activities that this intervention will look into or implement to see if this goal can be achieved. Is conducting the training of the importance of triage. If you know, there were so many trainings conducted, but a specific triage training for staff was not conducted. So in this intervention is to look at that and ensure that staff understand the importance of why they're triaging and implement standard hours so they know everywhere across the facilities, they practice the same standards. Design and implement a reporting form that can be used at the triage. And this intervention doesn't have to be a form that will complicate the task of those who are doing, but a simple aggregate tally broken down by sex and age so that it can be easy for those staff at the triage to use. And these activities will be monitored. So triage compliance will be monitored, the number of staff trained on the process, a pre-post training survey to assess staff knowledge, confidence in doing triage, and attitudes will be monitored and evaluated. The daily report submitted to the facility manager by those who are doing the triage. Weekly reporting submitted to the Provincial Health Authority, and timeliness and completeness of those reporting form will be monitored. My study also is conducted together with another COVID-19 study that's done by one of our fellows, Dr. Mary Kaibakore, and her study complements my study as well. So we work together to do that intervention. And her study is looking at improving reporting of confirmed COVID-19 cases using GO data at the facility and provincial level. We acknowledge all our partners and sponsors. Our director for FETPNG, Mr. Barry Ropa, all our faculty members, both international and national, my mentor who supports me, the CEO for NCD PHA and management, our NCD surveillance lead person, and all our fellows for the support and interaction. So thank you.
Good morning all once again. I am Claire Andawa, working with the Catholic Church Health Services in the Diocese of Bernnie in Southern Highlands Province, aFET Fellow. I will present my intervention study on increasing level of awareness and knowledge on sexual reproductive health and antenatal care among pregnant women around the Rrte Health Center in Southern Highlands Province through community-based participatory awareness program from April to June 2022. Background and importance of the public health issue that this intervention study is trying to address. According to the 2016 demographic health survey, maternal mortality ratio remains high in Papua New Guinea, 171 deaths per 100,000 live births. And improving maternal health and service delivery are key result areas captured under the National Health Plan 2011 to 2020. Despite the supportive policies, national antenatal coverage decreased slightly from 51% in 2015 to 51% in 2019, according to the health sector performance annual review in 2019. And among many other factors that can influence the uptake of antenatal services, low knowledge and awareness on reproductive and maternal health could limit women from accessing vital services. According to the operational research that I have conducted, these are the key findings that came out from that operational study. The study was conducted in two components. One was reviewing the antenatal data at the facility, and the second component was assessing the knowledge, attitude, and practice of women in that health center. So the retrospective analysis of the antenatal data showed that 98% of pregnant women attended first antenatal care during their second and third trimesters, which pointed out that the math talked about achieving the early antenatal coverage was not possible. And in that analysis also showed that 55% of women who lived 1 to 2 hours attended the anti-clinic, and 21% who lived more than 2 hours accessed the anti-clinic. So for this particular women in this area, it showed that distance was not one of the factors that was hindering the access of the antenatal care. In that interview data for the knowledge, attitude, and practice study, among the 39 women interviewed, 67% of the women did not know or did not receive any information about sexual reproductive health in their early childhood to their teenage years. 43% not aware of health problems that a pregnant woman would experience during a pregnancy. And when asked about family planning methods, 64% women identified contraceptive as the available family planning method, and a less number of women, or among them, less number mentioned about other available family planning services. So based on these findings, it pointed out that the pregnant women had low level of knowledge and awareness about sexual reproductive health and the importance of early antenatal care in that area. So to address this issue, the objectives of this intervention will be to increase the antenatal care services uptake at that center in Southern Highlands Province. That is, how can giving awareness to the women, educating the women, can increase the level of their knowledge in order for them to access the antenatal care services provided, so that it can at least help them to address the issue of high maternal mortality ratio. So the objective is to improve level of knowledge and awareness on sexual reproductive health and antenatal care among pregnant women, following a community-based participatory awareness program. So what is the intervention now for this to address the mentioned problem? Conducting awareness sessions among pregnant women using community participatory approach. As I have said, community participatory approach. So the women are given the antenatal, when the women present at the antenatal clinic, they are given awareness and education as the antenatal package when they enter the antenatal clinic. But according to the study that I did, that did not reflect. Most of the women who came through the antenatal service, but still they did not know, they have low knowledge about the importance of antenatal clinic and sexual reproductive health. So this study will be evaluated by grouping the women into two groups. One group of women, pregnant women, will come under the control group. The control group will be the number of women attending the antenatal clinic who will receive the same package of the training, but at the antenatal clinic as part of the standard routine antenatal package. And the intervention group of women will be receiving awareness and education in the community based in the community as a participatory approach, which means in-depth focus group approach in the community. And to assess the level of the knowledge gained, pre and post test will be administered to compare among these women if they have any differences among them, to assess the type of approach that we can use to educate women. The prepared approach that can direct us to do, is it the normal routine that we are doing? Can we continue on that way, or we have another approach to deliver the message to increase the level of knowledge for them to access the services? Thank you.
Good day, everyone. I'm John Landime from Nawai District, Morobe. I'll be presenting my project, an establishment of respiratory clinics to improve triage and infectious control practices in the health center. So these are the respiratory clinics that were built during the COVID-19 pandemic in the districts. So because of the transmission of COVID cases, this intervention came about. As you know, respiratory disease are easily transmitted when patients are together in
a common setting in outpatients. And with COVID-19 imaging, it's very scary, and given how fast COVID-19 can transmit when people are together in a common setting. Between August 2020 to July 2021, we saw 778 cases that passed through outpatient, of which we detected 60 out 8% of them. And this is still a challenge, and this a potential for spread of COVID-19. I did a operational research, and a common symptom that appeared with people coming to the facility is cough. That prompted the idea of creating these clinics. So I built 4 respiratory clinics to divert cough patient away from the normal outpatient to access in a respiratory clinic. So these were the 4 respiratory clinics that were built during the pandemic. The map shows where they are located. Torowa in Iraq. We have Buana, that's the district headquarters of Nawa district. Then we have Asitum, that's close to Lake City. And Bua, that's close to Finsaven, it's along the coastline. So these are the respiratory clinics built, people waiting to be served. And these are some of the settings of respiratory clinic and people waiting to be served. Apart from building the respiratory clinics, we did IPC trainings, infection prevention control trainings, to all the health center staffs in Buana, Torowa, Bua, and Situm. Training on donning and doffing and cleaning principles. So they will be better prepared to run the clinics and look after patients. So the clinics are built, staffs are engaged in working. What I'm going to do this next couple of months, 2 months, is to just monitor and evaluate, and then do data analysis again of those that enter the clinic in this period, just to see the difference if they are getting service in the respiratory clinic. So I'm going to do some descriptive analysis again, compare with the previous one that I did, and then also do some surveys on staff knowledge and attitude, and if they are actually doing the IPC measures in that center, and I mean the respiratory clinics. And also, I just want to find out if the community is aware of that and are willing to access these clinics. And also, I'll be just observing staff using checklists, seeing if they are actually practicing the IPCs and actually seeing patients in the respiratory clinics. In the long term of these clinics, we might see a reduction in TB, and we might also see an increase in detection of TB cases, other eyelid problems, also COVID-19, and we can also see an increase in swabs in the clinics, and also detect outbreaks quickly if we created this one-stop shop idea of getting coughs into a certain location. So that will be a project done in the next 2 months, and I'll report back. But I want to thank all this, the FET team, the partners, the Morobe Project Authority, the districts, and the staff that were behind me in this project. Thank you.
Hi, everyone again. My name is Roslyn Gatana. I'm from the Autonomous Region of Bougainville. I will be presenting my project, my intervention project, on a research that I did in 2019. But because of the pandemic, we were not able to come and present. So the research was to assess the barriers to accessibility and availability of health, frontline health services, healthcare services in Buka district. So today I'm going to present my intervention project, and it is to assess the benefits of supervision, monitor, and feedback report to improve immunization coverage in Buka district, not Bougainville. Health systems in PNG are fragile, and efforts to try and improve this is still a challenge to all of us. Most of the rural health facilities have poor access, and that could be due to bad road conditions and challenging terrains. Some health infrastructures have been maintained, some have not over the last 10 years. There are also other issues that affect service delivery, and that includes inadequate remuneration, insufficient training, like when the COVID-19 came in, all of us did not know how to manage COVID-19. So things change over time with medicine. So we need to continue to train our staff so that they can be able to manage these cases. Lack of proper incentives to motivate staff, and also lack of medical supplies. When we look at our SPA report from the last 5 years, we have seen a decline and maybe some little changes only in our key performance indicators. With health system strengthening, we have looked at the barriers and those availability. If we have the service, is it available to the people in the wherever we are coming from? If it is available, is it accessible? And can people afford that health service? And if they can afford, do they accept the type of health service that we provide? The graph shows the key findings from the healthcare workers' perspective on how we can improve the healthcare services in the district, in the facility. There was these are the common things that I picked up from the questionnaire, from the survey. If you look at the graph, most talked about staff accommodation. Most has facility staff, they live in the village and they come to work every day. So as we know, nurses are on 3 shifts. That is morning, evening, and in the night. So if he or she is on night duty, what they do is they come and stay at the health center and wait for their shift. So staff accommodation was a real issue. Regular management and supervisory visit, that is also important because sometimes we just leave them there. We don't go back and check how are they doing. Are they implementing the program? So that is also very important. Staff salaries and incentives. We know that health is highly industrialized and we have our own awards. When we don't pay them or when we don't attend to this, it can also demotivate our officers, our staff in the facility level. Community awareness on the range of services. The community also need to know what type of services we are providing at the facility level, whether it's at the hospital, health center, or at the aid post level. Regular monitoring on feedback performance. Most times health workers, we provide a lot of data, but we don't get the feedback because maybe people are not doing the job. Maybe they don't know how to provide the feedback back to the facilities. Water supply and sanitation is also very important. There must also be water available at where we are coming from, where we are working at the facility level so that we can be able to do our jobs properly. I just highlighted 4 main key issues that I will be looking at during my intervention. That is regular management and supervisory visit, ensure availability of medical supplies, community awareness on the range of services, and regular monitoring and feedback on the performance. My goal. The goal is to improve management support for frontline healthcare services. And like I said, I will be looking at 3 interventions. One is regular management and supervisory visit. The second one is regular monitoring and feedback on the program performance, and to provide continuous management coordination for the implementation of the immunization program. These are the activities and the outcome that I expect from this intervention project. One is to conduct weekly supervisory visits to the health centers, update the supervision checklist, and train the OICs. The outcome is the staff are able to use the checklist to monitor their program activities. Second one, like I said, is to conduct monitoring and feedback. Follow up with the staff to provide twice weekly activity report, provide weekly feedback on activity performance. The outcome will be the facility staff are able to monitor and follow up on the immunization coverage. The third one is to actually plan and implement the program, ensure that there are vaccines available at the facility, very important. Conduct scheduled clinic and vaccinate the children, and community awareness. We know that during this, and even now with the COVID-19, there is vaccine hesitancy. So we need to engage the community. We need to do the community awareness before we go and give the vaccines.
because people, mothers are hesitant to bring their children for vaccination. How will I monitor, or what will I monitor? The number of visits conducted is very important. Number of feedback reports given to the facility, the total number of clinics conducted, and also the total number of children vaccinated before the intervention and after the intervention. These are just some of the photos to show what is happening back in the province. As you can see, our logistic officer is fixing our fridge. If you don't have a fridge that is working, then you will not be able to store your vaccines well, and you want to have vaccines to go and vaccinate. The second one is the launching of the polio campaign. We need political support. So that is, in there we can see our health minister with the cap. He was the one who launched our polio campaign. So we need to get political support. The third one I was talking about is the community awareness. Before the start of the clinics, we need to give that awareness to the people, to the mothers, so that they understand the importance of coming and getting the children vaccinated. I would like to thank these people for helping me in this research, especially as you can see in the photo, we have this Bougainville Healthy Community Program. So these are the VHBs, the volunteers who help me with the research, and they also help us to mobilize our community during any health programs. Thank you.
Okay, thank you, Elsie. I think let's give a clap again to the 4 presenters for the feedback. We are looking forward to your interventions, and then when we come back in June, and you would be able to show us the results of your intervention, and then we can share with other people as well the findings and the outcome. For now, I think we'll come to the last presentation from me, is to give you a review and preview of what we have been doing in FETPNG training program. Just before I go into that, I want to also acknowledge the FETPNG training graduates here, who are fellows in advance, who are actually the frontliners in the current COVID response program. We delayed this training to this date because of the surge in COVID, and we can't even get them out. This is like a break to them, but we know that Omicron is still around, and we don't know, how much is out there in the country. But thank you for coming and showing what you have been doing. There's more behind these stories. I think they've been involved in COVID response, and in the last week they shared all this experience from different areas they've come from, and I'm sure they've learned a lot from each other, and also the faculty members also learned a lot from what they shared. I just want to give you some highlights. In 2020, we did the FETPNG did a swabbing study, and this study was done in PNG by our FETPNG graduates, and the report was made available to the department and also the NCC, and also the health in the respective PHAs in the provinces. And this was done in collaboration with FETPNG, NGOH, NCC, WHO, and St. John's in Papua New Guinea. We also did the 2020 swabbing study engagement with Bernnie and Barry did as a lead person. There was a preliminary report presentation done at the task force meeting in 8th February 2021. Also, there was an FET fellow experience writing for publication to SafetyNet, field evidence day on the 7th of September 2021. Bernnie also published findings in the International Journal of Infectious Disease. And thank you, Bernnie. We can give a clap to her for putting FETPNG on the global map, PNG FETPNG. All right, and in 2020 as well, we did the after action review with NCD Rapid Response Team. After we did a training, we carried out after action review at the hotel next door. We did some key areas identified the key areas for future improvement on the training, and learning lesson from there. I think we've carried out other trainings so far, seven trainings in the other provinces. So that report is also available. We made that available to NCD Health Services as well. Also in 2020, we have done after the surveillance evaluation, provide recommendation on strengthening COVID surveillance in PNG. This also, there's a report available and made to the department as well as NCC. In 2021, we did carry out the vaccine efficacy study. It demonstrated that healthcare workers are most trusted source of information for PNG public. And this was done through the collaboration with FETPNG, NUH, WHO, St. John's and UN report. So that report is also available, and it was, as you would see, it was found that most of the the public get the report, the information from social media, 57%, and then they also get 46% from internet search, interestingly, and 40% on newspapers. So in 21, we also did a vaccine extensive study engagement, which Mata Pogo as she's one of our FET graduate, and she's been now promoted or elevated to the EPI program in the National Health Department of Health. She did engagement with the national media briefing on COVID-19 vaccination in PNG. She also presented in the Royal Australian College of Physicians Pacific Public Health webinar on the 25th, 27th of May, 2021. Mata Pogo and also Bernnie did a presentation of training program in emergency and public health intervention network, that's FETPNG, at the global meeting on vaccine at the 20th of May. And so Mata and also Bernnie did a presentation on Australia Regional Immunization Alliance vaccine roundtable meeting on the 27th of July. So in 2020, continue we did a rapid response team response initiation training in Oro by virtual, Gulf, AROB, West New Britain, Western Province, and Western Islands Province, and Morobe. And after action review was done for Oro. It was done virtually, but then the after action was actually on physical visit to the province. And also in the same year, we developed the Rrte modules, and this is available online. In 21, we were able to conduct the Rrte, develop the Rrte modules. That's module 1 is introduction of the Rrte. Module 2 is outbreak investigation. Module 3 is preparation for field investigation. Module 4 is conducting a field investigation. And module 5 is follow-up post-field investigation. Again, this is available as a resource for us to use. In 2021, the intermediate FETP CFOL accreditation was achieved from the United Nations Institute of Training and Research. So thank you, James and the team, for putting together that, helping the PNG FETP again to be recognized and accredited by the United Nations Institute of Training and Research. Okay, thank you. And we have recruited a team of support to the FETP office. That's Benny as the course convener, and Dia, Ola, she's here. Dia is at the back as a program officer to support the FET training. And thank you for providing the finance from DFET as well as WSO for supporting for the IHR. component. And also we have, we welcome Dr. Embal Yamba, who is the frontline coordinator. You here in the room? No, he's not here, but I think he's attending a virtual meeting somewhere. But so we have 3 additional FETP staff supported by partners, and they are now stationed in the National Department of Health. I've also allocated a permanent office for them, and they have an office to work in, so you can call in and sit down. Okay. So we've done PNG FETP Internal Ethics Review Board established and approved by the MRC, the Medical Research Council. And so we have now been officially recognized. It's the first in the country for a body within health department. Also, in areas of health in PNG, to be first given an ethics review committee of our own. It's a subcommittee. The papers have to go through our committee from all our fellows who are doing the research. And once we feel that it meets all the requirements, we will let it pass through the MRC. Right. Again, thanks to the team to have this accomplished. So in 2021, we did send out the invitation for nomination of candidates. In terms of getting nominations, we don't just pick people. We send an invitation to the PHA CEOs and the senior staff in the provinces, and we send them the criteria of selection. And if they do meet the criteria, they nominate themselves from the PHA to come and undertake the training. And then because this year, 2021, we decided to get almost half of the participants for various reasons. We used to get something like 16 candidates. We've now come down to 9 candidates. We've had some virtual sessions with them already as introductory, preparation for them to come using the Zoom because they're actually supposed to start last year, but we didn't. So, instead of them waiting around, we get them through some introduction to them. So introduction, intermediate ethics training, public health surveillance, and outbreak investigation. And that will be done next week. Okay, in 2021 also, we have re-engaged with the advanced fellows. There's been a lot of delay in the training. We started the first phase in 2019 December, or just end of November and December. But we just did not discontinue. We continued our engagement with the fellows when they were out in the field in visual sessions, and we had introduction to using Zoom, how to use Zoom. I didn't know much about using Zoom until I came around the FETP, or even at the headquarters level here. So I'm sure the guys on the field would have been also the same. So they learned how to Zoom in, and have sessions on Zoom. That's probably one of the good things that the COVID has brought about. We never use Zoom, but when COVID came, everybody knows Zoom. Okay, then they had visual project presentations, and they did the first phase of the project, the intervention design. They also took part in the surveillance evaluation and also the outbreak report. See, the advanced field projects, we have different thematic groups. They divide into these groups: the health system strengthening group, maternal and reproductive health, vaccine preventable diseases, communicable disease, and COVID-19. And this is very important. That's the very reason why I always try to, as a director or program convener director, I always try to make sure that the public health people do come and attend training sessions or presentations. Or I'm happy to say that there are a few of them here from HIV and non-communities, and also from the PHAs and policy planning and PHA secretariat level here, so that they can see that FETP at first was taught only about outbreaks, only about surveillance. Now it's not only about it, it's all about all the health programs, whether it be clinical or public health, or we also go into animal health as well. We've trained one of the first FET graduate from I think second cohort was from the animal health. So we diversified, so we're not just sticking to the core people in disease control. It's all public health programs plus, anybody who's involved in health. Yeah, with the 2021, we also done some professional development for our faculty. That's Bachelor of FETPNG, attended the World Health Organization in epidemics course. Gilbert Yawalia, who's out here at the back, and also Benny did a Thailand FETPNG mentorship training. Dr. Ebeli Amber and Alice Provena, One Health introductory course at the Human Environment Wildlife Livestock Interface for the Pacific. Senior and junior faculty transformational leadership training. It's still ongoing now, underway. The frontline FET training program, we've secured a global fund to do that in 6 provinces. Initially started with 2 provinces, West New Britain and Sundown province. We have engagement with the multiple national and international partners exploring One Health approach for the frontline. As you probably might notice in my last slide, we tried to capture that by having a technical advisor to look into the zoonotic and human health interface. Hopefully we can get that one. And we had a stakeholder workshop on the 9th of December, focus on surveillance outbreak response and community engagement on the front line, and then engagement integration with village health assistance. The National Department of Health has changed a policy or accepted a policy to change the village health volunteers to call them village health assistants. What that means is that they will no longer be volunteers. The curriculum is still the same, but we will give them incentive in a way of put them on a I don't know whether it be fortnightly or whether it be monthly, but some form of salary for them to be our the lead person in the community, in the villages. So that's also, I think, for me as a surveillance and emergency response program manager, I think that's very good for the program, so that we can get the reports right at the village level, and not only reports, but they can be our also first line responders in terms of getting data and also do the what they call the public health interventions, which you don't need medicines to do that. So looking ahead in 2022, we are in 2020 in March now. It's coming to the end of March, and we're almost into April. We are going to start our intermediate FET training program, which is cohort 8. We plan to start in early May, hopefully, towards the end of April. We're going to do a pilot frontline FETP in 2 provinces. That's West New Britain and Sundown. We visited West New Britain already 2 weeks ago, and we will be visiting Sundown with Singapore. That's his province. He's the deputy director for public health there. So we have a good leader there. So we will go over there and visit that place very soon. We also plan to do a train the trainer for a senior and junior faculty during our intermediate FET training program, where we have our senior faculty members here, and we bring some junior faculty members to develop our own capacity here in country. And that's a very important part of our program to sustain the program in the country. And we're going to complete completion of a transformational leadership training that we will have to complete. We'll have to complete a 2-day Rrte initiation training in the remaining provinces. We've done 7, and we've got 15 more to go, right? If the numbers are correct. And maybe soon after that, the government just approved a few more districts and provinces, so I don't know what the number would be. Then we have to do Rrte after action reviews in multiple provinces. We have already advertised and selected Rrte training, Rrte coordinator, which is yet to be recruited, and we just finalizing where the source of funds, and we're able to recruit it quickly because the candidate has already been identified, selected, and ready to join us. So he'll be our fourth person in the FETP training program supporting me at National Health Department of Health. We also plan to recruit the frontline coordinator that will support Dr. Abel. We also have a plan to recruit 4 surveillance officers to be recruited, and these are against positions that are vacant in the National Health Department. And we are going through a restructure of the health department. Hopefully, these guys could be retained when the positions are available and advertised. So we plan to that. And also in this year, we are planning to do the 5-day rapid response team competency-based training. It's a full 5-day. When what I said earlier was a sort of a introductory training, the 2 days training. And after that, we'll go and do the 5-day, full 5-day competency training. And we will also plan to do the executive training developed and piloted later in the year. Okay, just to give you what I've been really busy about in the last, I don't know, 4 or 5 weeks, and I'm still, my head is still heavy because I slept at 2 o'clock in the morning and then I have to work out at 5 o'clock about the development of structure. This is the proposed sort of a structure. The most important one on this one you would see is that I'll try to capture the FET training program, technical advisor there in the middle. They have given in the new structure a possible executive manager for health security. It's a new one in the health structure. And I have, and my team have put together a business submission and then also justification of why we should have, that branch or that, branch established in the department. Under that would be the Central Public Health Laboratory and a National Reference Laboratory. We have the surveillance and imaging response, which will do the routine surveillance system that's ongoing now. Like when I say TA, IBS means TA, technical advice indicator-based surveillance, like for polio and measles and those routine stuff that come through our system that we do. And a technical advice for event-based surveillance like rumors and community-based kind of a surveillance system, newspapers, TVs. We get that a lot when the campaign is, election time is on, people can report anything. We also have the technical advice for vaccine preventable disease. We have the technical advisor for hospital-based surveillance. This is because of the, I think the experience that we had in Goroka and also places, I think, and some other hospitals when we had a measles outbreak and we had cross infections and that stuff. We want to work with the infection control officers to do some kind of active surveillance in not only hospitals, but all the health facilities. So that's quite new. It is new. We also have a TA or technical advisor for emerging and re-emerging diseases. That's where the COVID will sit, right? And we have a technical advisor for zoonotic disease and human health and animal health interface. So that person will work closely with Nakia. We have some form of understanding and working together. Already, as I mentioned earlier, we have a trained FET graduate in Nakia already in the lab. So we try and work out some way of how we can work together to do surveillance for animals as well, because our health network is much bigger than their network, and we can help them to do some little bit of work in the field and share information to them on what we see and on where we are. All right, and the new one, which is in the middle, is managed surveillance and response system strengthening. All right, so we have the technical advisor for international health regulations. So we have a specific person looking at some of the core activities that the state must do and have to meet the international health regulations requirement, and just to keep on track and see that those supposed to do have it and then maintained. And we have the TA field epidemiologist I mentioned, technical advisor community-based surveillance system, which will link with the village health assistance and the frontline FET training program that we're going to do. We have the technical advisor for Public Health Institute. We have technical advisor for partner coordination during disaster and emergency and outbreaks like this. In our small unit, we had difficulty managing, partners, that are coming and going, and where they're coming from, and whether they're in Papua New Guinea, they were in overseas, or what specialized they are in. We just want to keep track of those things in term during preparatory, so that we know where to go when we need them. And we have technical advice for laboratory support to link up all our surveillance system, and then in terms of looking at the training and equipment and sample shipments. So we put in a lab. At the moment, that position was supported by WHO, but the person has already left. So then we have the rapid response team coordinator, and that rapid response team coordinator will also be responsible to assist in provinces the function of the provincial EOC. Right. See that the office still function as as it was established, whether that purpose is still serving or not, and maybe looking at your system like an IT and also the functionality of the team, and whether you're meeting or not, that person will be the key person to coordinate that. On the other hand is more about CPHL. There are five or 60 different program areas. The serosurveillance, HIV, TB, food and water, malaria, and EQA. So they're not Q&A, but yeah, EQA, the quality assurance assessment stuff. So they've got 6 programs. Under that, they've got all different kinds of support stuff that comes with. So these 3 program areas make up the health security branch. Okay. So as you see on the right-hand corner, we have the PHI secretariat. There will be a secretariat made of the heads of all the public health programs and different organizations to assist the department in terms of drawing out a plan and also the act and the strategies developed. Maybe we're looking at in the next 5 years, we'll have those things prepared, and hopefully when the PHI is in preparatory part is complete, after 5 years, most of this stuff will move into PHI, including the training and research and the laboratory will be housed under PHI. Would be similar arrangement like IMR, where the government funds it, but they operate separately. Your reporting system that you send to the ENHIs will also go in there, so that we have independent assessment of what you're doing in the programs in the province. All right, so they can evaluate programs as well. So that's brief on the structure. Sorry, that I did that already. All right, I think I'm Tasu. Thank you very much for your attention, and thank you for coming. And that's why I end my presentation.
Thanks so much, Barry, and everyone that was presenting. That was really great overview of a lot of activity over the past 12, 18 months. We're excited for the new year. It will be a busy year with our fellows doing the interventions, but we'll look forward to going back in June. So everyone is welcome to stay for lunch. We're going to head downstairs to the Stanley restaurant on level 1, and everyone is included. So please stay for lunch if you can. And catch up with the fellows on the month program. And enjoy the rest of the day. Thanks for coming. Fellows.
Yep.